My name is Courtney Barkley. I am a senior in public health, and this summer I was one of the students on who took the travel course Exploring Population Health on the Road in the Deep South. So to give you a little bit of background about who took this course, there were 6 undergraduate students, 8 graduate students, and 1 doctoral student. And this course took us around the Deep South, and in 12 days we visited 4 states, 9 cities, and 20 public health locations. So there was a lot that we got to see and do at these locations. And the sheet that Dr. McCormick handed out earlier lists those locations and a brief description of what we were able to do at each location. So in this course, we had a few different purposes. The first few are mainly, it allowed us to observe public health concepts that we have learned in class and see those in practice. We were also able to observe the health disparities in our region of the United States and see how multiple perspectives contribute to the public health initiatives in the South. We were also able to see the various levels of public health management. We saw different levels of the management in health departments, local clinics, which my peers will talk about later. And then we also observed how public health is an interdisciplinary subject. We were also able to enhance career development through networking with these locations that we went to. And we wanted to raise awareness about the health disparities that affect the South. So in this course, to help us identify key themes at each course, we first defined population health, health equity, and social determinants of health before we left for the trips. And we developed our own, a definition for each of these within our class. And then as we went to the different locations and talked to the different professionals, we applied these to what we learned. And you will see these themes throughout the rest of the presentations.
Hi, my name is Jennifer Schusterman, and I'm a dual master's degree student here at UAB, and I'm going to talk a little bit about history in the Deep South. As we drove along what were once dirt-covered roads in communities much smaller than there are today, we learned about the histories, the very unique and rich histories of the Deep South. I'm sure many of you have probably heard the quote that those who do not remember the past are condemned to repeat it. But what does that mean from a public health standpoint? That means that we need to consider the fears, we need to consider the distrust, and we need to consider the overall health experiences of the communities that we're working with. If we want to be able to create successful public health programs, we need to understand the history of the community that we're working in, especially if it's a community that we do not share that history with. So when I was on this trip, which was an incredible experience, I learned a lot about the rural South. And 2 cities that actually towns, communities that stood out to me on this trip were Baxterville, Mississippi, and Tuskegee, Alabama. Baxterville is the site of an atomic experiment that took place during the height of the Cold War. And due to the fact that the federal government did not necessarily communicate well with the community with what was going to happen and the side effects of what happened in Baxterville, which I'd like you guys to look up and learn a little bit on your own, the community has distrust. We went to lunch with a family of Dr. McCormick, and she even mentioned, the family member, about this ongoing distrust 40 years later. In Tuskegee, Alabama, if you don't know, it's the site of a 40-year-old syphilis experiment. The 40-year experiment, the people that were a part of it were unaware of what they were being subjected to. The individuals that were a part of this experiment did not get treatment that they so desperately could have had that would have improved their health outcomes. So we in public health need to realize that if we're working with communities that have distrust, that have fears of people that are healthcare practitioners, we need to learn how to build bridges. We need to learn how to create a trusting relationship with those communities we're working with. So I implore you, if you're going into public health, which we all are, You need to understand the history of the community that you're working with in order to assure the best public health outcomes.
Hey everyone, I'm Claire Oriema. I'm in the dual MBA MPH program, and my focus is in healthcare organization and policy. And one of the, was this supposed to be my slide? It's my slide now. So in all of the sites that we went to, we were able to see the intersection of all of the different focus areas in public health. There were multiple sites that applied to healthcare organization and policy, multiple that applied to maternal and child health, health behavior, environmental health, epidemiology, global health. And so that's what we're going to go through in this order, is we're going to address and tell you some stories about the sites that we saw that really had an impact on us as students in these particular focus courses. So, like I said, I'm an HCOP, and one of the many benefits that I got from this course was to be able to envision myself working in different organizations. When we're learning about public health in class, it can seem all very theoretical, but going out into the field and being able to see if I could work in a health department or not, or what aspect I would like to get into, that was really helpful for me for trying to form, my potential career path after graduation. The first site we visited was the Mississippi State Health Department, Department of Health, MSDH. And it was really a good foundation, because after this we went on to visit health departments on a local level, a regional level. We got to see a tribal health department and even look at some federal health department initiatives. So starting out with looking at how is public health administered for the entire state of Mississippi was really helpful for us. We met with most of the leadership of the state health department. And if you see here on the right, there's this list of services that they cover. And if you're anything like me, you didn't necessarily know all that a public health department covers. You might think in terms of licenses and records, or think in terms of disease surveillance, but not all of these things. They're in charge of WIC, the Women, Infant, and Children Care. They're in charge of informing the public about diseases, about health initiatives in the area, about how to get access to care, immunizations, making sure that the standards of care in hospitals and clinics across the state is at the appropriate standard. And so it was incredible to see such a small number of people in charge of all these vast services. And while we were there, they were kind enough to give us some of their time and tell us about some of the department's key priorities, which are disaster preparedness and relief, women's health, hepatitis C, and health behaviors such as obesity, exercise, smoking, and healthy pregnancies. And what I really appreciated is that they were super honest about the struggle and the kind of difficult in-between position that they hold. They have to sit in that area between giving funding to local organizations, to nonprofits, and also going to legislators and politicians and trying to get that funding and trying to communicate to them the importance of the initiatives that they're trying to do. And so that's definitely a tricky and very diplomatic type of role. And I appreciated that they, despite having very diplomatic language, they were honest with us about that it can get really difficult with clashing values when they want to communicate that there's a health problem and politicians don't seem to care about said problem. It can be really difficult. One of the clearest ways that that was shown was in their budget, which is that pie chart on the left. The big yellow section, that's about half of it, that's all federal funding. So all of that is designated to specific programs. Just like if we were to get an NIH grant here at UAB, we'd have to use that for the exact purpose that the grant was written for. Couldn't just put that towards whatever initiative we thought was going to be the most important now. So all of that, while it was there, it was designated. The green section is kind of for fees and other administrative type of things, such as the licensing and keeping standards of care up and whatnot. So really, the area that is important to focus on is that little blue sliver. That is the amount of funds that they had out of their total budget as like flexible funds, what they could put towards initiatives into new programs that they thought would be the most beneficial for the people in their state. And the legislature in fiscal year 2017, cut 10% of that small blue sliver. So having funding cuts, having to tighten up their belts, having people have to take on multiple roles when really new people should be hired for those roles to expand the programs, that was kind of some of the things they were telling us about, which gave me a really realistic picture of the challenges that we face going into public health and working for a health department.
Hey everybody, I'm Catherine Toms, and I'm in the master's program here at the School of Public Health, and my concentration is maternal and child health. So I thought it was a great trip because we did really get to take the theory and the practice that we learned in the classroom and see it in a variety of public health settings and see the practical aspects to it. So I saw maternal and child health in virtually every site we visited, but I'm going to keep that, reduce that down to 2 sites to tell you about. The first one is the Mississippi State Sanatorium for Tuberculosis Therapy that was active in the 20th century. Tessa's going to tell you more about that later. I'm just going to concentrate on one particular program, and that was the Preventorium. I think it's a great historical example of how we as public health professionals need to meet the challenges of the population that we serve. The program offered residence to children between the ages of 4 and 11 years who were at risk for tuberculosis. So what's at risk for tuberculosis? It's the same today as it was 100 years ago. So it's malnutrition primarily, tight living quarters, reduced immune system, and exposure to someone who actively has tuberculosis. So that was their population that they took in, and they had a limit of 50 children when they opened the program in 1929. So that was the year the stock market crashed, and over the course of the Depression, they had a growing population that came. So more and more parents were less able to provide for their children. So I think this is a great example of how public health professionals had to think outside of the box and expand their programs to include a bigger group of people. And that way they were more able to serve the population. So those are lessons that we can take into the future, and how we can stretch our resources and the definitions of our programs to serve the public. So my second site that we visited was the Daughters of Charity in New Orleans. So this is a Catholic organization that has 10 clinics in the New Orleans area. And these are primary health centers. The Daughters of Charity dates back to the 1700s, and it's been 180 years in New Orleans. So the clinic that we visited provides free or low-cost, comprehensive, patient-centered health care to an underserved community. The clinic is designed to eliminate barriers to accessing health care to all its patients, but I'm just going to highlight the programs for women and children. So, for example, the clinic can provide transportation services and organize multiple appointments on the same day for their patients. So, for example, a struggling mom can get dental, vision, pediatric, and gynecological services all in the same day at the same location, which is important. And even the layout of the clinic reflects this thoughtfulness for the population that they're serving. They have the women's clinic just across the hall from the pediatric clinic, so it's easy access. So also the WIC office, which provides nutrition services, and the pharmacy are also housed in the same building along with the other services. This hypothetical mom we're talking about can get glasses for her preschooler on the same day that she goes for an eye exam for the child. And then after Hurricane Katrina, they saw a growing need for intervention services, counseling, and behavioral intervention programs. So they expanded those. And all of these coordinated services enable our single mom to keep herself and her family healthy. And by really understanding the struggles and barriers that their population faces, the Daughters of Charity is able to help overcome these obstacles and improve the health of the population that they serve. So I think they're an excellent model for future clinics throughout the U.S., and I'm sure that you'll have the same opportunity to experience maternal and child health if you're thinking about going to Panama in the spring. And I'd just like to thank you for listening, and thank you, Dr. McCormick and Mina, for everything you did, from the planning to just troubleshooting and the whole shebang. Thanks.
Hi. My name's Katina Kudreff. I was the doctoral student on this trip, so I'm currently studying health education and health promotion. And as we know, health behavior is a very, very large part of that. And I wanted to take a second to focus on the ethics behind everything that we do. So like Jennifer mentioned, we got the opportunity to visit Tuskegee, Alabama, where this, gross violation of human rights happened, and what led to the formation of the Belmont Report. And if you all haven't heard about that before, your professors have not done you justice yet. Right? I mean, this is like intro-level public health. Let's talk about beneficence, respect for persons, and justice, okay? And so we were able to go to Tuskegee and talk to people who had been there and see relics from this experience. And for me, that really brought it home. I've heard about it so many times in classes, from my undergrad to my master's to the PhD. We just keep going over it. And because it's important. Right? It's really important. But for me, until I was there, until I talked to the children and the grandchildren of these men who had been in the study, until I visited the Great Oshiala Baptist Church, where these men were recruited for the study, it didn't really hit home. And so we keep that in mind as we move through, and I'm actually going to take us back in time on this trip. Because Tuskegee was actually one of our last stops. But before that, we went to Jackson, Mississippi. And as Claire mentioned, Mississippi Department of Public Health, their budget is limited. Their ability to do things can sometimes be limited. And so it often comes down to their community partners to do a lot of the local, really evidence-based and impactful work in specific communities. Jackson, Mississippi has some of the highest rates of HIV. Mississippi itself has some of the highest rates of teen pregnancy. Health disparities run amok. And what My Brother's Keeper has done, while they started as an HIV service organization, they've really expanded to call themselves the denouncers of health disparities. So their entire goal is to engage with their population, find out what they need, and provide a service that meets their needs to reduce those disparities and increase health overall. So one example is actually a shirt that I'm gonna step away from the microphone to let you all see. If you couldn't read that, it said, talk is the perfect foreplay. And so when we think about HIV awareness, you can't know if somebody has HIV unless you talk to them about it, right? We want to talk to them about condom use. We want to do all of those sorts of things. So My Brother's Keeper worked with Act Against AIDS, which is a federal program, to run this campaign in Jackson, Mississippi. And that way, we reduce some of the stigma around HIV, enabling folks to take part in preventive behaviors. Another program that they did, I mentioned those high rates of teen pregnancy. Mississippi overall doesn't do the best job at sex education. In fact, they're not allowed to provide sex education in most cases. So when my brother's keeper saw this, they were like, well, that's a problem. And said, we're going to provide this education in an evidence-based way that we're going to continue evaluating to make sure that it is working. And so their evaluation team is working on that, and I don't have the results yet, but hopefully, at least in Jackson, Mississippi, it will be reducing rates of teen pregnancy along with STIs and HIV. So as far as health behavior goes, it was all over this trip, but these two were really the ones that stood out to me.
All right, I'm McKinnon Carter. I'm an undergrad with a concentration in environmental health. While traveling throughout the Southeast, we were able to see the immediate impacts of public health in the population. One of the stops was the Auburn Animal Diagnostic Lab, where we met with Dr. Stephanie Ostrowski, and she told us about rinderpest and how to rip through the continent of Africa, which kind of opened up for colonization throughout the continent. But it affected cattle, also known as cattle plague. 99% of all cattle that contracted the disease died, causing agricultural loss as well as the Great Ethiopian Famine. We also met with Dr. Tony Frazier, and he opened with a statement, and he stated that a country that has a lot of food has a lot of problems, but a country that has no food has but one. And we learned that he and his team monitor the livestock population for disease such as E. coli or rabies before the meat goes to be processed and sold in the markets. Another stop we made was in New Orleans. We went to the Lower Ninth Ward as well as the Katrina exhibit. And natural disasters have effects that last for years after their onset. 13 years after Hurricane Katrina, New Orleans is still seeing effects. The Lower Ninth Ward at one point in time was the only place that African Americans could purchase homes. And right here you can see we're standing on the levee along the Mississippi River. And if you are familiar with the city, you know that the French Quarter is somewhere right in here. And along the east of the Ninth Ward, which you really can't see in this picture, there's an industrial canal that collapsed and leached out a lot of hazardous materials into the floodwaters. Currently, New Orleans as well as the Lower Ninth are facing the rising sea levels due to climate change. And I think that one of the main things that kind of tied everything together for me in this trip is that through seeing all of this, it made sense of the One Health approach, which is using or utilizing the One Health approach, which is through prevention and preparation, I guess kind of intertwining animal health, human health, and as well as the environment around us. Thank you.
So my name is Tessa Graham, and I'm currently an MPH candidate in epidemiology. I'm sure everybody's heard of epidemiology. When you think of it, I'm sure you think of more of like the scientific part of public health, maybe the more boring part of public health. All we do are studies all day, but there are two kind of main things we look at in epidemiology and try to figure out, because that's what we want. We want answers to our questions, and that is disease distribution and disease causation. So through this trip, it kind of illuminated to me the results of our work, which in epidemiology we don't often get to see. A lot of us, we don't really do face-to-face contact with people in public health. We're more behind the scenes a lot of the time. So one of the sites I would like to talk about was UMMC in Mississippi, which we discussed biosafety with trained professionals and went through personal protective equipment and things like that, which normally is more associated with environmental health. But it's kind of a result of epidemiology through studies and things that these practices are determined. So seeing that actually in effect, where you can see one of our students, Angie here, She had to put on the equipment. We all did. And we got to go through all of the protocol that has previously been determined to be sort of the best protocol for PPE to kind of keep yourself from getting infected. And the men we spoke with were very knowledgeable. They had experience previously with the most recent Ebola outbreak. So it was really good to kind of get that firsthand knowledge from them of a kind of key tenet of public health, which is prevention. And that's exactly what PPE is used for. But also at UMMC, they had another tenet of epidemiology and public health, which is surveillance, or how we collect our data. They have a MedCom, which is a medical communications kind of control center at the university. Is exactly what you think you would see in like a CIA operative intelligence center. Just wall-to-wall monitors, data coming at you constantly. They have video feeds of all the roads and kind of key places in Mississippi so that they can kind of keep a handle on everything that's going on, which is sort of the point of public health. And then the other side I would like to talk to you guys about is the state sanatorium in Mississippi. So TB was a huge problem throughout the United States, as we kind of touched on with our history portion and with Catherine. And so many states opened up sanatoriums. Alabama had quite a few. Bryce is the more popular one. There's still one right over the hill in Mountain Brook that is now apartments, if you can find it. And this sort of kind of came about from early epidemiology, and that's another part of this. You see how it changes over time, especially through this trip. We don't use sanitariums anymore. The belief sort of used to be we can isolate, quarantine, whatever word you want to use for what they did here, those people from the general public, and it would give them clean air and space to be around other people with TB, and hopefully they would heal, or if not, at least they're there and not in the general public. We know today that that's not the best way to treat TB, and these practices have changed through studies and through application of public health and population health that we studied, and that is the whole point of what epidemiologists study, is the populations. But now these practices have changed, and even though TB is still an issue for Mississippi and other places around the country, they have methods in place, such as people, ex-military, things like that, that go out and enforce medications in order to kind of cut outbreaks and limit spread. But it really was a wonderful trip. It's so different to learn about public health in a classroom and to actually go and meet with real practitioners who have real experience and can actually show you, well, we started with this idea and we moved here and now this is the result. And I think this is a great way for all of us to kind of see that and get re-energized for public health.
Hi, I'm Bijal. I just graduated with my bachelor's degree in public health, and I'm getting my master's in biomedical and health sciences. And so I got my concentration in global health, and I went on this trip as an undergraduate student. And so traveling throughout the Deep South, you wouldn't really think that there's a really big global health aspect to it, because we're really focusing on the disparities here in the United States. But at every site, you could really see, like in global health classes, we always talk about think globally, act locally. And so that's something that you saw at a lot of our sites that we went on. And two really prominent global health topics that we went to was the Centers for Disease Control and Prevention and the Carter Center. So at the Centers for Disease Control and Prevention, we got to go see the Ebola Museum. And so it kind of highlights what we learned at the biosafety at UMMC. And so we got to learn about what was happening in Africa, about the outbreak, the complications and the barriers that they had to go through, such as overcoming cultural beliefs, religion as well, and also distrust. There was a lot of distrust, and a lot of the locals didn't believe that Ebola was actually there. And so we actually got to go throughout the museum and read testimonies both from physicians and nurses there to actual people that live in Africa, and kind of get more of a perspective of what was happening. And so another thing that we got to see was also the iron lung chamber, when we learned this a lot about when we talk about polio. And so it was really nice to actually see actual artifacts when we talk about these diseases. And so another global health thing was the Carter Center. So we talk about the success of eradicating smallpox, and we lead that conversation to say Guinea worm's going to be next. So the Carter Center one of the things that they focus on is the eradication of guinea worm. So we got to meet with James Zingesser, and he's the senior project advisor for the guinea worm eradication program. And so he's one of the people that actually goes to Africa and like goes throughout the villages, trying to treat people and like figure out better ways to eliminate treat people. And so we learned about how villages, they would have no cases of guinea worm, and then all of a sudden they would get it again. And so there was like, well, we have to go there and understand why that's happening. And one thing that we learned was that there's a new vector. We're seeing guinea worm in dogs, and so you would get rid of guinea worm in the human population, but now with the dogs getting it, it's reinfecting the humans again. And so that was one barrier that we got to see that I never really learned in the classroom. So actually talking to a specialist about that was fantastic. And so another thing that really tied the whole entire trip together was what Dr. Zingesser said, and that's that we're smarter together. And this highlights how we have to bring all these different various fields together in order to eradicate a lot of our public health problems.
Hi, again, I'm Claire Oriema, and I'm going to bring you a couple takeaways that we got. Obviously, through going through each of the disciplines, minus biostats, which of course you have to understand biostatisticians were behind collecting all the data at all of these sites in all these different areas, so of course very crucial. All of us coming from different backgrounds and in different areas of study, were able to gain some really important experience in the field and seeing what public health looks like for all of these different disciplines. So returning to our themes of population health, health equity, and the social determinants of health, we were able to look at that in every area. We know here in the South that we face challenges of systemic racism, of widespread poverty, of educational disparities, and we were able to truly see how all of these things, these social determinants, impact public health and cause poor health outcomes. One of our main takeaways was systems thinking. Sometimes we want to be like a savior. We want to, go and fix it all ourselves and do everything and think that we're going to completely solve a problem alone. That can't happen. That's not possible. This trip really showed us that there are so many systems involved in public health that we have to work with legislative systems. We have to work with educational systems, family systems. We have to learn cultures and work with religious entities and work with community organizations. All of these different systems have a role in helping us to achieve the goal of better health outcomes. We can't just make that goal happen on our own. Some of the challenges that we observed, everywhere funding was a challenge. Public health is severely underfunded, in part because we are a reactionary society. We don't put as much stock and importance into preventative measures as we do treatment measures. One of the areas where this was really obvious was at the Mississippi State Department of Health, where we were told they were given a block amount of funds for HIV prevention and treatment, but a really small portion was for prevention. Most of it was for treatment, which doesn't necessarily make sense since it's a lot more cost effective to prevent the disease than to treat a patient throughout their life. But because we're reactionary, that's how the funding was distributed. Another area where that's really obvious is in disaster preparedness. Dr. McCormick could tell you a lot more about that. Basically, there was no disaster preparedness plan before Hurricane Katrina. And now post-Katrina, even though New Orleans is not fully recovered, there are some plans in place, but they're insufficient. They're not comprehensive enough. So that is a challenge that as public health professionals we need to be aware of, and we need to try to address and try to change and try to work through these particular challenges. The final takeaway was one DeKennon mentioned, which was the concept of One Health. And it is really the concept that everything is interconnected. healthy environment, healthy animals, and healthy people all go together, and we can't focus on one at the detriment of the other two. That if we ignore climate change, that's going to affect animal health and human health. If we ignore having healthy livestock and healthy agriculture, then of course that's going to affect nutrition, it's going to affect people. So as we pursue public health, we have to see that we're kind of all players in this, but none of us are going to be able to accomplish it on our own. We all bring our different strengths to the table, and if we all play our part, then we can bring together this comprehensive idea of One Health, and we can pursue better health outcomes for the communities that we work in. So this was a very beneficial trip, really great to be in the field to get to experience all of these different things. And now that you've heard a little bit about our trip throughout the Southeast, we'll welcome up Dr. McCormick to give you a little tidbit about the next one.
Okay, so a little bit about Panama. So if you think this was interesting, the kind of things that they got to see and do, then and you want to kind of learn about these same things but with a different population, well, you should consider joining us in Panama. We are going to be able to tour and look at Panamanian healthcare systems. We're going to look at how public health services are delivered in Panama. We're going to learn about their priority health concerns for their populations there across Panama, not just in Panama City. We're going to be looking in communities right outside of Panama City, 10 miles away around, that have way different issues than what you see in Panama City. And then we're going to go to Chitre, which is about 4 hours outside of Panama City, to another kind of more rural community, and look at issues there. And we'll be touring Santo Tomas, which is the largest hospital in the country in Panama City, but we'll also be going to a hospital in Chitre. We're going to go to health centers in Panama City. We're going to go to a health center right outside of Panama City that is really in a poor area where more of the indigenous population lives, in housing that is really built out of subpar materials. So it's way different than what you see in Panama City. So I think we're going to be able to see kind of the challenges with health equity in a different context than what we saw here in the U.S. So Panama is a developing country. It's not considered third world. It's developing, but they are still, they still have a lot of problems, and there's a lot of disparities. There's a lot of economic, social, and political issues that are contributing to these disparities in their country. So we're going to look at all of those things when we're there. We're also going to, look at some historical events that have shaped Panama. Panama, if you're not familiar, and I'm going to skip really quickly to this one, is a land bridge. So there were some geological events that occurred, volcanic eruptions, that created the land bridge here. And this contributed to the biodiversity in the Americas. Animals in the South American continent was able to cross this land bridge into North America, and animals in North America were able to cross into South America. But you think about the issues now, there's a lot of human trafficking going through this area. People that are coming into South America trying to get to the United States and actually being sold into slavery in Colombia and other countries, and then moving through Panama. So there's a lot of women's health issues, but one is human trafficking, and that's something that they talked about too. They also told us, Mina and I went not long ago, about the Darien Gap region. We will not be going to that region. We can't go to that region, but it's interesting to hear about some of the issues in that region of the country, which have issues that we don't have to deal with here in the United States. But it's pretty much a lawless area. It's a lot of jungle, and the Panamanian Highway actually ends before you get there, so they don't even travel through that area. So But a lot of people get sold into slavery in that area, so there's a lot of issues. We're going to go to the Panama Canal. We are going to visit a museum that talks about the history of the Panama Canal and the building. Dr. Gorgas and the infectious disease work that he did in quelling the yellow fever and malaria outbreak in Panama. And Tim just told me, Mina, that he has a lot of information on Dr. Gorgas and what he did in Panama over in the archives. So hopefully we'll be able to go to the archives, before we leave on this trip. And then thinking about the Panama Canal, now it is a source of economic stability for the country. So the United States has passed control of the Panama Canal to the Panamanians, and they're generating a lot of funds for their country. Now, how they're using those funds, I'm not really sure, but it's kind of causing some issues in the country, positive and negative. So we're going to look at some of those. Environmental impacts, not only the environmental impacts from building the canal initially, but they just expanded the canal. Now these bigger ships, these container ships, they rebuilt sections of the canal to handle these larger ships, and they've actually had to go in as the Panama Canal comes out into the bay and the ocean there. They've had to dredge out all of these areas for these bigger ships to get through, and there's been some environmental impacts. Even, when we were there, it's very warm there. There wasn't many people swimming in the ocean there, and we found out later the reason is because the currents are so unpredictable, and part of that is because of the dredging. It's affected their shrimp and fishing and aquaculture. So we'll be looking at some of those issues too. I'll also be going to the ruins of old Panama City. We're going to learn about the culture and the history of the whole land bridge area from the beginning of known time in that area, and talk about the indigenous populations that were there and that live there now. They do have issues with classism and racism, and how these, we're going to look at how those issues are affecting health equity in their country today. So, and I hope that we get to do some service learning and things like that while we're there around health education and health promotion. We're going to do some community health assessments, some windshield assessments for some of the communities that we're going to. So I think it'll be a lot of interesting thing, again, over different of these cross-cutting areas of public health. I think we're going to be able to see a lot even in maternal and child health and women's health issues. So here are some important dates if you're interested in the course. The application deadline is January 1st, and the first payment has to be made then. Now, it's going to cost $2,150 is the cost of this trip, plus there's a $125 fee that you have to pay education abroad. You also have to pay tuition, which is for 6 credit hours is what this course is worth, and the flight, and you may have to have immunizations depending on your immunization history. So that would be kind of the cost. You would have to have, if you're a U.S. citizen or if you're anybody, you have to have a passport. If you're not a U.S. citizen, a visa may be required, and we will have to work out those details with education abroad. But there's a link there to the site if anybody's interested. And this course has been approved towards the Global Health Certificate Program. So if you're interested in getting a Global Health Certificate, you can take this course, and this can apply towards 6 of your credit hours. And Anna and the folks in the Sparkman Center can give you more information on that. So the good news is that the first 10 students who submit an application and pay their first payment will receive a $500 travel stipend, which will almost pay for the flight there. I think our flights there were about $600 or $700. And so you won't get that stipend immediately, though. It won't come until the class makes, and you make sure that they're not going to refund you money because the class didn't make. We have to have 10 students in order for the class to make. I will tell you that there are 12 students that have already started the application process. 4 of them have paid the $125 fee, but nobody's paid the first payment yet, which is not due till January 1st. But the first 10 that pay that fee and the first payment, which is like $1,000, I think, the first payment, will get the $500 travel stipends.